Now for a session produced by the Family Heart Foundation on addressing a public health crisis of inequitable proportion.
Okay, that means I'll go right here, Laura.
Hello, everybody. Good afternoon. I hope you're enjoying your lunch. Thank you all for being here. What an incredible morning it's been. It's been such an interesting and inspiring session. Thank you all for being here. We really appreciate it. My name is Davis Ahmed, and I'm Vice President for Policy and Outreach at the Family Heart Foundation. I'm going to tell you a little bit about who we are in a minute. And I'm here and I'm honored to have with me this wonderful panel here today. We have Ms. Aura Williams in the middle, who is a Family Heart Foundation volunteer advocate for awareness. She is also a person living with cardiovascular disease, and she's going to share a bit of her story here today. I would like to say that today is Aura's birthday, so maybe we can have a round of applause for Aura. She chose to spend it with all of us. Thank you, Aura. I also have on the in the red Dr. Elizabeth O'Feely. She's a practicing cardiologist and professor at Morehouse School of Medicine. She's the past president of the Association of Black Cardiologists, an organization that the Family Heart Foundation is very proud to partner with on several fronts, and we're thrilled that she's here today. She's also the CEO of AccuHealth Technologies and the global principal investigator for the African American Heart Study, so doing great work. We're glad to have you here. Just here to my right, want to make sure we get it right. I have Dr. Daphne Ferdinand, who's come to us from New Orleans today. She's Executive Director of Healthy Heart Community Prevention Project for Community Health Workers, and also the co-chair of community programs at the Association for Black Cardiologists. So thrilled to have Dr. Ferdinand with us. And on the end, we have Catherine Wildman, the founder and CEO of the Family Heart Foundation. So our program is a little bit different from the rest of the day, so I just want to let you know what's to come. Catherine's going to I'm going to say a few words, and then Catherine's going to give a brief presentation to help set the stage for you. We're here to talk to you about cardiovascular disease, drivers of cardiovascular disease, and the inequalities and inequities that we see in cardiovascular disease. By that I mean heart disease, stroke, peripheral artery disease. When we say cardiovascular disease, it encompasses the impact on the vascular system, and that's not just the heart or the brain, but other parts of the body too. So I hope you'll stick with us as we use that language. So Catherine will give a presentation, and then we'll have our great panel discussion, and then we hope to have some time at the end for Q&A. So please, we look forward to your questions. So first, I just wanted to say a little bit about who the Family Heart Foundation is. We're a national nonprofit research and advocacy organization, and we're focused on preventing cardiovascular disease, heart disease, stroke, aortic valve disease, caused by inherited lipid disorders, so disorders that are genetic, that cause high LDL, for example, a common but under-recognized disorder called familial hypercholesterolemia, and also high lipoprotein A, and that's another genetic driver of cardiovascular disease that is very common, 1 in 5 people, but very underdiagnosed. And that means that we focus a lot on, what are the drivers of cardiovascular disease, and what can we do to prevent them. So I'll say that I started as a volunteer 10 years ago because I have high LDL cholesterol and live at risk for cardiovascular disease. We're a patient-driven organization. We're very proud to we have 3 patients on the stage here today to share our perspectives, myself, Aura, and Catherine. So everything we do is really, it was so exciting to hear what people had to say, because everything we do is answering the questions and the challenges that we as patients saw. But we took a data-driven, medically evidence-driven and and patient-driven approach to solving these problems that we hope that you'll join us in solving today, that we hope we inspire you both personally and professionally to join us in doing something about cardiovascular disease and the disparities in care that we see. Our goal is to change the outcomes in the people that we serve, and I think the audience and our panel represent the multi-stakeholder approach that we take to solving this problem. So without further ado, I want to hand it over to Catherine Wildman. She's our founder. She started the organization after she had a heart attack at age 39 and learned later that it was really caused by the high LDL that she lived with due to familial hypercholesterolemia and high lipoprotein A. So she's going to share some of our research and our real-world data and help you understand the challenge we face, and then we'll turn to the panel discussion. Thank you.
Thank you, Kat, and thanks to everyone on the panel for joining us and everyone who's here in the room and watching from home or wherever you are. I'm going to begin with, it's kind of a depressing topic. What are we most likely to die from in the United States? And the resounding answer is cardiovascular disease. And it has been the same answer for decades now, since the 1950s. But when you talk about cardiovascular disease, people usually don't have, the back of their neck tighten up. It feels kind of ho-hum. Nobody thinks about it as the big bad wolf. But the data show that it is a real threat, and in America, this is a little bit old data, but I think it's very interesting that means about 30% of Americans could anticipate dying from cardiovascular disease. But there are a lot of misconceptions, because when we look at what do people search for on Google, we see that they're only searching for information about cardiovascular disease about 2% of the time. And topics like cancer and road accidents and diabetes and suicide loom much larger in the American psyche. I think this slide's also great because we're all here at an event that's hosted by The Atlantic, and it's good to reflect what is the role, and what role does media play in shaping the narrative. And what we see is that, for example, in 2016, the New York Times did not cover cardiovascular disease very much. And I think that's something that we should all reflect on and something we could do something about. So today, we're going to do a very brief deep dive into one of the main drivers of cardiovascular disease. There are others, like blood pressure, and certainly lifestyle and obesity and diabetes. They all contribute to cardiovascular disease. But one of the most studied relationships is LDL to cardiovascular disease. And what we know is that if your LDL cholesterol is lower, you are less likely to have a heart attack or stroke, and that it's incremental. So every amount that you lower your cholesterol, if you lower it 40 milligrams per deciliter, you have a protection of about 20%. So the Family Heart Foundation does a lot of big real-world data analysis, because we hear from a lot of people who suffer from cardiovascular disease, but we want to be able to quantify what are the larger patterns. So we have a large real-world database, and we recently did a study that we've published, and I'm going to just share 2 slides on that data. This is very current data. What we found is about 38 million high-risk individuals, and more than 70% of those high-risk individuals never reach their LDL goal. The reason we call this a public health crisis is, one, the scope of it, but 2, the fact that we have had for decades now the scientific knowledge and the medical therapies to address LDL incredibly well. So I was born with familial hypercholesterolemia. When I was 15 years old, it was discovered that my LDL cholesterol was 385. That's extremely high if you're not in the medical domain. And today, on the medications that are available to me, and I had to fight very hard to get all those medications, My LDL cholesterol is 30. Now that's a miracle. And in the meantime, I had a heart attack, and I'm lucky to be here. But we have the tools to address LDL cholesterol today. What we see in the data, though, is of the 30% who get to goal, they don't stay at goal. There's a poor understanding within the population and not enough urgency or communication within the clinical ecosystem to actually tell people how important it is that they actually stay on these medications, take them every day or every month or every 2 weeks, depending on how they're prescribed. But we also see that the health system isn't set up to support people taking medications that they need on an ongoing basis. Oftentimes, people have their health insurance companies that they pay to be a safety net for them, tell them, even if they've been on a medication successfully for months or years, that they have to do more paperwork to get their next prescription filled. So there are barriers that are in place in addition to understanding. And about a third of those patients, of these high-risk patients, never receive any medication at all. Let's go to the next slide. So in our data, we also have a lot of information about the prescribers. And what we see is that 80% of clinicians, nurse practitioners, physicians, are never prescribing more than one lipid-lowering agent, even though the guidelines recommend that you use multiple agents to get someone into what we call at the Family Heart Foundation the safe zone. And the impact of that is that if people don't stay at their goal and they don't get the medications they need, they have more cardiovascular events, as you can see from this last point. So this is an overall problem, our treatment and urgency around cardiovascular disease, but it's even worse for some. And what we know is that if you are white, you're more likely to be prescribed guideline-recommended care. If you have a high income, that's actually one of the biggest differences. What is your income level? Makes a huge difference in whether you're prescribed. And then how much education you have. We also know that if you are a person who is Black or Asian or someone who is female, that you're less likely to achieve your LDL goals. And there are multiple reasons for that. So I just have 2 more slides to share with you. Today in America, if you are Black, you have a 30% greater chance of dying of cardiovascular disease than someone who is a non-Hispanic white. And unfortunately, we see some of these structural biases emerge. If you have been prescribed by your healthcare provider to get lipid-lowering medication, your insurance company is more likely to reject that prescription. In other words, they're less likely to pay for it for you, as well as you're less likely to pick it up. And there are multiple reasons for that as well. So when it comes to women and cardiovascular disease, women are even less likely to ever be prescribed any lipid-lowering therapies to lower their risk of cardiovascular disease. And there was a recent study that was done here in Boston, I think it was just published last week, that shows that women too have kind of perhaps internalized the narrative that they are less at risk, which is untrue. Women are just as at risk of cardiovascular disease as men, and it is the greatest killer of women, but they're less likely to accept the medications. So I just wanted to set the stage, because when you say heart disease and LDL cholesterol, people think of, the Wheaties commercials in the 80s and feel admonished that they should be doing more themselves, when it really is a true urgent medical risk. And we do need to change the food that people eat and how much they exercise and the other comorbidities, but we can do an awful lot about their LDL that we're not doing. So I look forward to the conversation with this panel. Thank you.
I almost forgot my microphone. Thank you so much, Catherine. It was a great overview. I hope you all took something away from that for yourselves, and maybe you'll be checking your cholesterol after you get home. Dr. O'Feely, I would love to know, you're a practicing cardiologist, and in your own research, how does this data that Catherine shared resonate with what you see in your practice and what the barriers are to better care?
Yeah, thank you so much for that question, and I am glad to be here. Thank you for the opportunity. So definitely resonates. So my practice is probably 85% African American or Blacks and 60% women. And the challenge with cholesterol and LDL is twofold. First of all, you have to go to a doctor to know what your level is. And yes, there are screening vans that come around every now and then they give you that slip, and then connecting it with your own healthcare. So I think there is as you stated, a sense that this is something that will gradually happen, and over time I will have the opportunity to address it. Unfortunately, we know, as we just heard, that there is a direct correlation with heart attacks. So one of the things that happen in my practice is, first of all, when patients have had the levels done, which the guidelines are, anybody who's 18 or older should know what their cholesterol is, and also the breakdown, including the LDL. That number needs to be followed over time. And so sometimes there is a reluctance, especially if people don't perceive the risk. And I think it is important, based on the guidelines, to put your risk in the context of what the larger data has shown, but also recognizing that there is some personalization involved. For example, we find that people with familial hypercholesterolemia are not sufficiently studied in the data that provides the guideline. So having a family history vaults you up right away. And if your level is high, and we generally don't want the LDL to be, definitely if it's over 150, and you don't even have any other risk factors, you should start paying attention as far as diet. But if you have blood pressure or diabetes or family history, we actually have a lower threshold for the LDL, not the total cholesterol, the LDL. So it's important to know the breakdown. And for my practice, I then tell people, because sometimes people will say, well, I've heard all this stuff about the statins. I don't know if I want to take it. And you're not going to force people. You said, okay, I want to do better with my diet. I said, okay, let's do that, but let's come back in 3 to 6 months, get another level. And the biggest instruction I give my patients is, we have to track this. Because most people, they want to do better, as you say, but they need to recognize what are the limitations of that doing better, and they work with data. When people then see that the levels either didn't come down sufficiently, or if they have certain risks, and I go ahead and say, okay, you know what, I'm going to scan your arteries. It's non-invasive. I can see what plaque levels are. If you come back and say, you know what, you do have early plaque. It's not enough for a heart attack yet, but it'll be good to have your cholesterol below a certain number. So I think all of those things people appreciate, but I absolutely agree with you. There needs to be sort of a 911, kind of saying, if you're 18 or older and you don't know what your cholesterol is, that's a problem. And then once you get it done, what is the plan of management with that? I know you said don't talk too much, so I'm going to stop here. We were coached in the back.
Well, that was fantastic, Dr. O'Feely. Thank you so much. I can't wait to hear more. But I think that's really important. The idea of checking early, knowing what your numbers are and where they should be. We'll share some of that in a minute. And starting early. Even one of the messages we have at the Family Heart Foundation is that the American Academy of Pediatrics recommends that all children should have their cholesterol tested between the ages of 9 and 11. So parents in the room, and if you have a history of cardiovascular disease in your family, or somebody in your family has high cholesterol, at age 2. So you can always visit familyheart.org to find out why and how you might want to do that. What I'd love to hear from you, Aura, about your experience and how having both high LDL and cardiovascular disease, and what you've learned along the way.
Told my story. Told my story. Yeah. Yes, I at 20 years old found out that I had high cholesterol. And so, and you guys know it's my birthday, so I'm 69 today. So we're talking 40 years ago, I found out that, I've told you I wasn't going to say that number again, so that's it. I'm done with saying that number. But anyway, I found out at 20 that I had high cholesterol. And through the path for the next few years, I put two and two together. My dad died early. His brothers died early, his sister. Early meaning before 60, before 55. And my dad had, I think it was 8 brothers. And so it was quite a few people that passed on. And you can almost tell which ones had the heart disease, because those were the ones that died early. So I was putting 2 and 2 together. Then when my brothers, because my parents had 12 children, I was the 12th. So when my brothers got to be in their 30s and 40s, they started having heart attacks. And then my oldest brother, who was in his 40s, had a heart attack and had bypass surgery. 6 months later, he passed. So I was really adding it up, even though I was being treated for high cholesterol. And I was one of those fortunate people. I'm educated. I had good insurance. And so I was able to go to good doctors, but they could only tell me what they knew. And they could only guide me where they knew to guide me. So no one was telling me the difference between LDL and high cholesterol and the genetics of it. You just think, oh, my dad died. Oh, yeah, I got to watch that. You know, they're telling you to watch your diet. So I started off early taking whatever medicine was out there for cholesterol. So there was no statins at the time. But then when statins came along, I took the best statins. And I have one of those bodies that I don't have a problem taking medicine. A lot of people, they do have a problem, but I didn't experience that. So I took what I thought was the best medicines and whatever the doctors prescribed. And I exercised, I walked, I even have done a half marathon, I've done a quarter marathon. I was in it. I was doing what I was supposed to do. And then one day, I woke up on a Saturday morning, and I had a crook in my neck. And so I couldn't get it out. I couldn't get it out. So Monday morning, I went to work, and I called my doctor and said, I've got this crook in my neck. I can't get it out. So he said, come in today. That was on a Monday. Came in, got the EKG. That Wednesday, I got the stress test. That Friday, I was in for surgery. I had open heart surgery, 3 bypasses. So, but I never had a heart attack. I never had high blood pressure. I didn't think, I thought maybe I had missed it. You know, I'm not going to be one of those people. But it happened to me. And then when it did happen to me, I started looking into other things. And then I started being treated as a genetic person. So I was never treated as it being genetic. I was always treated as someone who was probably overweight or probably had the wrong lifestyle or whatever. But once I got treated for the genetics, then I got better. And by the way, along the way, I also lost my son at 38. Didn't know he had it because I just assumed that they would catch it just like they caught mine. I thought that he's an athlete, he plays football, he wrestles, he's done sports ever since he was a little kid. Surely, if he had it, the doctors would tell me. No one checked. He didn't know. And so he died suddenly, just like my brothers did, just like my uncles did, just like my dad did. So my story is to be an advocate for yourself. And then we'll talk about that more probably. But that's my story. And start putting the dots together. because they'll lead you as a lay person. Now, the dots will lead you, but you have to connect the dots. Thank you.
Thank you, Aura. Thank you so much for sharing that, and we're so sorry that you lost your son, and grateful that you share your story to help other people. And I think Aura's story points to how important it is to advocate for yourself and to understand the condition. Dr. Ferdinand, I'd love to hear, you work with community organizations and community empowerment and community health workers. So how does activating the heart health community have an effect? What's your experience, and how can patients and communities work to do better?
Well, good evening, good afternoon, and glad to be here too as well. But as you have heard so far, it is really difficult for patients to overcome making sure that they can reduce their risk for cardiovascular disease. 80% of clinicians are not prescribing the proper medication to help those high-risk patients that Dr. O'Feely mentioned that had comorbidities, diabetes, peripheral artery disease, hypertension, kidney disease. All of these diseases, all of these conditions combined increases that individual's risk for heart attacks and strokes. And if we don't have doctors who are prescribing not just one statin, but another lipid-lowering agent to help them to reduce that LDL cholesterol to the level where they can be in a safe zone, we're going to lose a lot of folks. So what we do, but first, before I go that far into that area, how many of you all know your LDL cholesterol? Just looked it up. Just looked it up. Okay, that's a small minority of hands in the room, because the people who are listening to us over the radio, they can't see, right? Okay, so how many of you all know where your proper goal should be in order to be in that safe zone?
Can I ask you a question? In relationship to HDL, what does it mean?
Oh, very good question. LDL means low-density lipoprotein. That's supposed to be the bad cholesterol. The high-density lipoprotein, HDL, is the good cholesterol that chunks away of the bad cholesterol in your body. But sometimes lifestyle, exercise, proper diet, all of those lifestyle behaviors are very, very important to work with your cholesterol. But some of us need a little help. And that little help may be some medication. And this is what our patients need to stay on in order to break the curve. Patients in communities breaking that curve, we need to get them into treatment. We also need to break some of these barriers for access to care. And what our community organization in New Orleans tries to attempt to do that. And the way we do that, especially if there are access issues, we go straight to the community. We go to people where they live, work, and play. So we provide them that information. We did an 8-week diabetes program a year or so ago. We got a grant to do that in the heart of the community. But the way we were able to accomplish that is our collaboration and partnership with those organizations that also work and live in that community. They were our trusted members to give us the inroads into that area, for them to trust us and believe that we would be able to provide this type of education to them. And diabetes is a risk factor for heart disease, so we got to be careful of that too as well. So, but I am also a trusted member. I consider that as well. And the reason why is because I worked in that community. The people know me. I've lived around them for a number of years, and I don't lie, don't cheat. I tell them the truth. All of that is very, very important when you want to engage with community so that they can believe what you are trying to educate them on, the information that you're trying to impart to them, is that they can feel confident, that they can rely on you, that they believe in you, and they will accept the information that you are providing to them, and probably or hopefully to internalize that and practice that. So that's one of the important things that we found that has worked for us. We've done cholesterol screening in the past. That was one of the first activities we started with our nonprofit decades ago. So we've been doing this kind of work for a while, and people want to know. They are very interested in their health. I've had more people to stand in line after a seminar waiting for the results of their cholesterol test versus a blood pressure. And blood pressure is just as important. But it's not as easy, like Dr. O'Feely mentioned, that you have to have a physician or a practitioner who's going to order that test for you to go to a lab to get your blood drawn to find out what your cholesterol levels are. You can have a blood pressure cuff at home and take your blood pressure very easily, but it's not that simple with testing for an LDL. So we need to have some access available for people in order for them to get care. And we also need to be engaged in communities in order to develop those trusting relationships so that we can give them the information that they can use to empower themselves, to take action and advocate for themselves and their health.
Thank you, Dr. Ferdinand. That's very powerful and ties into so much of what we heard today and how important those approaches are. I think what we're trying to do today is to also to elevate the LDL cholesterol amongst the other important risk factors. And I'd love to hear, I think there are a lot of things that get in the way of better care and certainly other things that contribute to disparities in care and inequities. And I wonder, Dr. O'Feely, if you could say a little bit about what in your experience, what are some of the things that get in the way of treating patients?
Yeah. I just want to say, Aura, thank you so much for your story. And of course, excellent conversation across the panel. I think at the end of the day, people want to know how can they help themselves. And the issue is we're all busy.
Yeah.
And if something is not, it's a family, it's the hubby, you're trying to make sure hubby goes to the doctor, but then you got your own stuff that you think can wait. So I find that tracking, knowing what those numbers are, it doesn't mean you're going to get on a drug right away, but don't be afraid to know the number, because then you are on a path to doing what you can, but also, as everybody else has said, working with the healthcare provider, because I guarantee you, and it happens to me as well, when people come in, they have, in my practice, all these other problems we've got to address. Sometimes the LDL kind of, it's just a little bit high, we didn't quite get to it. So you actually have to say, oh, you know what, maybe I was at a screening in the community, these are the numbers I have. Sometimes they even do a scan on you. And just insist on somebody talking to you about that. But shameless plug, as part of AccuHealth Technologies, we do have Health360X platform. And if you want to go online, health360x.com, or on your mobile phone, Health360X mobile, you can download the app for free. But it allows you to track things like your blood pressure, your cholesterol, your physical activity, and different things that you have control of. So whenever somebody gets that number, you put it in your own database. That way, you're not waiting for the doctor to say, oh, that's what it was 2 years ago. Just put it on yourself to say, you know what, it was elevated. What else do I need to do? And I want to try diet, fine. Then you try it for maybe 6 months, as I said, and then we need to come back and check it again. And then you can see what else do you need to do. I think one of the things that I just don't want us to forget is the number of young people and middle-aged people that have dropped dead. They don't have bad habits, right? And maybe they're a little overweight, but that shouldn't kill people. Not right away. It takes time. So I think what you heard today is the power of the family history. If there's one thing to take away, is what is your family history? Better than any genomic stuff or genetics that people tell you, what is your family history? Yes, some people are adopted, they don't know the family history. Then that's when you start out with your personal history and you track it and follow it. So I don't want to, I'm very mindful of time. When you lean forward, I said, okay, that means I need to lean back. So I was like, I don't know if I answered all your questions, but I'm leaning back now.
I think that's so fabulous, and it's true. Heart disease, the progression of heart disease starts young, so there's no time to waste. I tell people because a lot of what we do is care navigation for people. They come to us with questions like, "What does HDL mean?" You can go to the familyheart.org, and we'll answer that for you. But why wait 6 months? Why not start the medication? If you need medication, not everybody needs medication,
Yeah.
but if you need medication, why wait? Why
That's
not
true.
get started? Get into that habit because the disease is not waiting for you.
Right.
I think Catherine
I
wanted
just
to.
do want to add, it's the risk benefit.
Yes.
So you have to look at the risks versus the benefit. If there are more risk factors, even if it's intermediate, we don't wait 6 months.
Right.
But, yeah.
And you should understand, most of the people that we work with, their LDL cholesterol, everything else is, their LDL cholesterol is 2, 3, 4 times higher than it should be. That's a lot of the population. That's 5 to 7% of the population. Yeah. And then there are all the others who are high, but maybe not quite that high. I think, Catherine, you wanted to say something?
I just wanted to say, I think we also have to acknowledge that when a person goes to seek care, there's a power structure. So part of what I hear people talking about is education's really important because it empowers people to push back appropriately or advocate for themselves appropriately. Or if you're tracking your data, then you don't feel that all of your health data lives with someone else and you have to get an appointment with them before you have access to your own data. So, when we're talking about inequities, it's interesting for me because the patient-doctor relationship, it has a structural inequity, and that's okay because the knowledge base is different. So I think that's okay, but I think there's also a place for empowering people with more information. Sometimes we tell people they have to fire their doctors.
Well, and actually, it's a great time to ask Aura, what has been your experience? I'm going to ask you a two-part question. Of what some of the barriers have been across your experience to getting better care, and how has being involved with the Family Heart Foundation for the years that you've been a part of our community and working with us, how has that changed the course of your care?
Well, I can tell you, Family Heart, at first, they were my rescue because I came to you shortly after my son died. And, I was helpless. Helpless, number one, because I knew I had high cholesterol. I knew I had heart disease. And I didn't do more. We always, especially us moms, feel like we should have done more. I didn't do more. I didn't make him get checked. So that's what first, you were my lifeline. And I jumped in. And then after I settled in a while and started becoming a bigger advocate, then Family Heart has become my Google. So when I hear about new medicines that I haven't heard about that came along, then I have asked, what do you think about this? When I heard about a research that was happening, I asked, what do you think about this? You think that this would be a good idea for me, a good fit for me? What I have done as being an advocate is I have researched myself way before the computer came along. Anybody know what Webster is? Anybody know who Webster is? Okay, me and Webster were friends, but then the computer came along and things got a lot easier. So when I found out about cholesterol, I found out what it meant to my arteries. I did not know, just because someone tells you you have a high cholesterol, you may not know what it is. So I had to find out what it was. It's hardening of the arteries. And then when I was prescribed statins, then I was taking statins. And then when I read about another statin that came along, Zydia, I got so excited about it because it seemed like it was going to change my life. And it did. So I actually wrote to the manufacturer and wrote to the people because I didn't have a cardiologist. So I went straight to the source. What is this medicine? Can I get this? How do I get this medicine? And then later on, when I did get a cardiologist, I started, I heard about this, other medicines that could really lower my LDL. So I discovered exactly what lowered my LDL. But I had family heart, and I had them, I would go to, we Zoomed, and I read a lot about it. So I helped myself. I was my own advocate. And now, I'm going to tell you all, I have a family reunion. I told you it was 12 of us. It's a whole lot of people that go to the family reunion. And now I have a platform. Everybody knows that I'm the heart disease girl and that I'm going to talk to them. They set aside time for me to talk and for me to tell them about the medications and explain to them not to be afraid to take them. And, if this isn't working for you, you need to look into a change. So they come to me. And we discovered that one of my great great-nephew, I think he was 12, he went and they found an LDL specialist for him. And he's doing well, but he had to be a pediatrician. So you have to do for yourself, and you have to step outside the box, and you have to tell your family to step outside the box, and then give them the okay. It's okay to do this. It's okay to take this medicine. It's okay to do, to talk to these doctors. So
Well,
that's my story.
Again, thank you. I love our panel, and when I got a sense of who might be in the room, I'd love to know more. I love that this is talking about, trusted sources, advocating for yourself, but on many of the different levels, right? On an individual basis and a community basis, with the healthcare providers, the health systems, like Mass General and Harvard and all of those, with a national advocacy organization who's here as a resource, with the industries that are working in the space. And then certainly we need a public policy approach and a health policy approach, because it can't just be the motivation of an individual. And so with that, I know we're getting close to time. I would love to start with you, Dr. Ferdinand, and think from your perspective, what are some of the upsides? What are some of the solutions? What can we all do to move things in the right direction and to address the inequities so that we don't perpetuate them? Instead, we make things better.
Oh, that's a good question, Kat. Thank you for that. Like Kat said before, I volunteer, and I'm also a member of the Association of Black Cardiologists. I play a very, very significant volunteer role with them as community co-chair. And we have a motto: children should know their grandparents. Just think about that. This cardiovascular organization that Dr. Feely had held leadership in is wonderful in that it makes such great attempts to reach out to community to change lives. And we have a community health advocate training program that I'm working with some all over the country. We have 10 sites, and I'm adding 5 more sites this year, where we train laypersons in community to teach their other community members how to lower their risk for cardiovascular disease. We go through the entire gamut of all risk factors, cholesterol being one of the very important ones, especially. And we use a text that's evidence-based from the National Heart, Lung, and Blood Institute, which is designed for the targeted population that we serve, African Americans, and is tailored in language so that they can understand and communicate the same language to their community members as well. So we have this program, which is absolutely excellent, and I feel that other organizations should consider working with similar organizations like the ABC. If you come from a workforce, consider that if you are looking at developing a cholesterol health promotion program in your work organization.
That's great.
Workforce cholesterol health promotion program.
So work with ABC, work with Family Heart. Dr. O'Feely, very quickly.
Yes.
Solutions.
Yes, so I just really want to come back to Aura's story. She told you when she started, there were no statins. She started on drugs that were not as effective, and yet she was looking for others. And then ezetimibe came along. She went direct to the manufacturer to get it. And then now we have what we call PCSK9 inhibitors. Those drugs would drop your cholesterol to, exactly. So the point is, there are advances, drug development, clinical trials, and this is where I want to end on.
Yeah.
The fact of the matter is, whether you're thinking about women or blacks, minorities in general, do not have access as much to these clinical trials. And if you don't see people like yourself, everybody's not like Aura. I mean, she is an unbelievable advocate, but there are people who look at that and say, how many people participated in this that look like me? How do I know I'm not going to have the side effects? So we are working actually through the study you heard earlier, the African American Heart Study, to begin to address things from an early development standpoint, so we know the representation in the clinical trials reflect who has the disease in the population. So we'll know what works for who and how.
And they
I
can
know you
trust-
got your microphone up again.
Trust.
See, I pay attention.
So you're keeping us on time. Thank you. And building that trust, it's multifactorial. I'll give Catherine, and thank you, everybody. I know we're at time. Maybe you have a couple of words to close on, Catherine.
I would just say that health is one of the most precious resources that we all have. And I think it's key to the changes that we want to make. I can tell you as a person, when you become unhealthy, it's harder to solve the larger issues. So I think it's a very basic issue and something that deserves being elevated and collaborating together on. And we really appreciate your time and your engagement, because I've seen in my own life and in the work that I do, it's individuals like yourself stepping up in systematic ways in your own life on a daily level that really do make a difference and bring about the changes.
Thank you. I would like to thank our panelists. I'd also like to thank the Atlantic for this amazing event, all of you for attending, Amgen and Pharma for underwriting the whole day, and our panel in particular for Amgen. Thank you so much. Thanks, everybody.